First of all, very good morning to everyone. I'm Dr. Seema, and it's my pleasure to welcome you all on this day 2 of the World Neurosciences Summit 3. I wholeheartedly welcome you all the delegates across the country, the chairpersons, the speakers of this program are uniquely placed to discuss, debate, and highlights the trends, key points, and reforms. So let's start this day with the full zeal and enthusiasm. So I would like to invite our eminent chairpersons for the first session of the day, which is Neuro Otology. I request Dr. Sushil Razdan, who is an eminent professor of neurology from Jammu. He has got more than 40 years of practice, along with multiple national and international publications on his name. Dr. Dinesh Udainiya, CEO and Dean of Government Medical College, Datia, MP, who has been honored with the multiple awards like Chikitsa Ratna Award and Dr. B.C. Roy Award. Dr. Mukesh Mehra, Director and Head of Department of Max Medical Subspecialty Hospital, who has got more than 300 of national and international publications on his name. So let's start the day with this first session. So I request Dr. Sushil Razdan, Dr. Dinesh, and Dr. Mukesh Mehra to kindly introduce the speakers for their respective sessions.
Good morning. I thank the organizers, especially Professor Arunji, for inviting us to this wonderful Medanta meeting. And it's a very important event after COVID years. We thought we'll never see each other, but it's been great to be together with all our friends. And we have very important topic of vertigo. In fact, who doesn't see vertigo? From orthopedicians, from ENT people, physicians, and in fact, neurologists used to see them last, but we are coming fast forwards now. And we have very good two speakers, Dr. Sudhir ji and Dr. Anirban. And the first topic is simplicity is the key, a simplified approach to the dizzy patient. We can invite Dr. Sudhir Kothari. Welcome, friend, welcome. He is a veteran of vertigo for last 20 years. He knows ins and outs about it, and I'm sure he'll make it so simple that all of us can revisit and understand the thing. Thank you.
Thank you, thank you, Dr. Razdan, Dr. Garg, for the invitation. I'm going to really try and simplify it. Of course, in 25 minutes, it's going to be a task, but let's see. So, just to put it in perspective, if you just take patients of BPPV alone, in Delhi, there will be around 500 new cases every day, if you count the rough calculation. In Pune, there are about 100 per day. So it is about 0.6% of the population per year gets BPPV. And it's extremely treatable. Of course, Anirban is going to show you how easy it is. He's going to talk on a simplified approach to repositioning. So he's going to show you how to reposition them. Okay, so this is what typically happens. You just want to find the blame something, either examine, do some X-ray, blame it on spondylosis, blame it on something found on the MR angio, blame it on the blood pressure, either high or low, or just look at the age and say probably it's vertebrobasilar insufficiency, probably it's some fluid in the, and then what do? You put on an intelligent face and then present it as you have vertigo. You know, this is the biggest joke. People are come to me and I ask them, what were you told you have? He said, I was told vertigo. So when I ask them, what do you mean vertigo? They look at me as if I am stupid. You know, how do I not know what is vertigo? So they don't understand that vertigo is a symptom. It's not the diagnosis. And then finally, what happens? You either prescribe drug ending or beginning with what, and that does the job. So to treat effectively in medicine, you need a diagnosis, and we are going to try and see how to reach a diagnosis. So in dizzy patients, it is all history. The history gives you the diagnosis in 80%, and then of course the eye movement examination. Sorry, I'm going back. So you want an easy approach. You ask the patient, what do you mean by dizzy? So if he says, I get a spinning sensation, I get a tilting sensation, that is called type 1 dizziness, and that is true vertigo. If he says, I'm feeling faint, then you say this is type 2 or pre-syncope, check the blood pressure, and often you may find postural hypotension. If the person says, I feel unsteady when I'm walking, that is type 3, and that is actually a balance problem. So it can be various disorders. We'll see that later. And type 4 is the ones which don't fit into anything. He says, I feel woozy, I feel a little numb in the head, and these are often psychogenic. Uh, if you diagnose true vertigo, then you look at whether it is central or peripheral. And therefore, you look at what are called the deadly Ds, diplopia, dysarthria, dysphagia. If the person has anything of that, if he has more of ataxia than vertigo, if there's no ear sign, all these things suggest a peripheral problem. And if there's something else, then of course central. Then once you diagnose that it is peripheral vertigo, look at the timing. If it lasts seconds, it is BPPV. If it is minutes, then TIA. If it's hours, many years, etc., etc. But there is a spoil sport. This doesn't work. Often, you know Murphy's law. If things can go wrong, they go wrong. And therefore, the problem is fitting the patient's symptoms into those 4 slots. Is it type 1? Is it type 2, type 3, type 4? It becomes very difficult and you can't do it. So, I would suggest you read this article, Dizziness Demystified, by the Australian group from Sydney, Miriam Belgampola. It's an excellent approach, and that is what I'm going to do. So, we reduce it into slots which are clear, which can go into only those slots, and you don't get confused. And so, life is going to be simple but not easy. And I remind you, my talk is simplified approach, not an easy approach. So there are 4 basic presentations. Don't try to see type 1, type 2, type 3, type 4. The 4 presentations are, is it acute vestibular syndrome? Then you think of vestibular neuritis or stroke. Is it recurrent postural vertigo, recurrent positional vertigo? Then mostly BPPV, sometimes central. Is it recurrent spontaneous vertigo? That is not positional. Then you think of vestibular migraine, Meniere's, and TIA. And then if it's balance disorders, it's a whole group of neurological disorders. We'll look at those later. And sometimes bilateral vestibulopathy. So this is what we are going to see. When the person comes with dizziness, is it an attack or is it a constant sensation? If it's an attack, then is it the first attack or is it recurrent attacks? Constant guys have constant imbalance. If it's recurrent attack, then is it positional or non-positional? So that will be our approach. Let's look at the first attack. Someone with the first attack is very sick. They will not come to your clinic. Most of the time, they will land up in the emergency department of the hospital. And let's look at one of these such patients. 82-year-old guy came with acute onset dizziness. Clinically, BP was normal, speech was normal, and he had a mildly unsteady gait. And these were his eye movements. So you can clearly see he's got an upbeating nystagmus. And this we know cannot be due to a ear problem, should be something in the brain. So he was somewhere else in another hospital. He had an old MRI done because he was diabetic hypertensive. He had some earlier symptoms. MRI was showing just mild few periventricular ischemic changes. A scan was repeated after 48 hours. Again, that was normal. So now what do? You repeat. When you apply the duck test, if it walks like a duck, sounds like a duck, and looks like a duck, chances that it must be a duck. So it all looked like a stroke, so it must be a stroke. And so you repeat a scan at 72 hours and it was a stroke. There is a small pontomedullary infarct. So the important point here is even a 3T MRI can be normal in a small lacunar or a posterior fossa infarct in the first 72 hours. If you suspect a stroke, repeat the scan at 72 hours. And I have had number of such patients where scans were normal and we repeated a scan at 72 hours. We treated as presumptively a stroke and then a repeat scan showed the infarct. We have sometimes, only once actually, thrombolized a patient who had a normal MRI just on the basis of the eye signs. So if a person has diplopia, dysarthria, and limb ataxia, weakness in a limb, or sensory loss, you know it is not a ear problem, you know it is a stroke. But what about those who come with just vertigo and maybe ataxia but no other symptom? What do you do with such patients? These are called the pseudoneuritis presentation of stroke or the vestibular neuritis. How do you diagnose these patients? So, a simple set of eye signs can help to distinguish between these two groups, and these are well known. Everybody knows the hints test, the head impulse, nystagmus, and test of skew test. This is an old article, 2009, but people unfortunately do not use the hints, the head impulse test too much, and I think that is something we all should start doing as frequently as we check fundus. Just every patient who comes to in front of you, practice the head impulse test. So this is the nystagmus of vestibular neuritis. It is unidirectional, that is keeps reading on the same side. For this patient, it is reading to the left, to the right, the nystagmus direction is like uh, if you have a central pattern of nystagmus, so the direction of nystagmus changes. When he looks to left, it beats to left. When he looks to right, it beats to right. Or it is upbeating like in that earlier patient, or it is downbeating, or it is only torsional. When you get these patterns, think of a central cause, and therefore in the acute case, it should be a stroke. So this is direction changing. It can be sometimes subtle. The person, when he's looking to the left, it beats to the left. When he looks to the right, there's slight right beat. But that little slight right beat is also important. That tells you this is a stroke. What if it is only unidirectional? It can give you a false sense of security because it looks like vestibular. Therefore, the hints protocol has these other two components also. You can't go only by nystagmus. You have to see the other two tests, and that is the head impulse test. So, what is the head impulse test? When a person looks at you and you tell the person, keep looking at my nose, and actually I'll show it on Dr. Razdan. Side, little jerk to the other side, and see whether his eyes are still on my nose. If there is a vestibular defect, you will see what happens to the eyes. So this is the head impulse test. I'm giving a jerk to the left, normal. Giving a jerk to the left, normal. And because normal means he's still looking straight at the camera. And now see what happens on the right. His eyes went to the right, and he had to make a corrective saccade to bring the eyes back to the camera. So you have to instruct the patient, keep looking at me or keep looking at the camera. Now this, of course, this video is slow motion. What you will be seeing is like this. This is normal and this is abnormal. So that little saccade is very important. You can always use your camera, and so most of the mobile cameras have got slow motion things. You can put it on slow motion, check it, or ask your houseman to do it and send it. Nowadays they send it and we tell, okay, this looks positive or negative. Skew deviation actually is one eye above the other. So for example, if the right eye is higher, when even if I cover one eye and I ask, look at this spot, this eye also will be looking at the same spot. So when I remove this, that eye would be looking there, you will not see any movement. But if one eye is down and one eye is up, when I uncover this, this eye which was down will come up. So you have to look for that up and down movement. So here, see, this is the patient. Of course, COVID times, you can see the mask. And this is in slow motion how it looks. One eye goes up, one eye goes down. So this is very easy. These tests take hardly 2 minutes to do. Look at the nystagmus, do a head impulse and do the skew. So what about this? What if the patient has sudden hearing loss along with the or tinnitus along with the vertigo? At least is this a ear problem, labyrinthitis or something? No, there is something called hints plus. So if somebody has sudden hearing loss or sudden onset of tinnitus with vertigo, be very careful. Around half of these could be an ICA territory, the anterior inferior cerebellar artery territory stroke. Okay, one easy way that Dr. Sergio Carmona, a good friend of mine, what they have found out is the hints is very difficult to teach physicians or general practitioners or CMOs. So they have found out this easy way. If the person cannot stand without support, if the person comes with vertigo and he can't even stand without support, it has to be a stroke. It can't be vestibular neuritis. And if the person has no imbalance at all, he's only vertigo, but he says, I don't feel imbalance, that is unlikely to be stroke. Many of them are in between and you have to apply the whole hints protocol. But if somebody is calling you on the phone and he says, I've got certain vertigo today, if he can't even walk, he must rush to hospital. It must be a stroke. How do I treat vestibular neuritis? Of course, not everybody agrees with this, but I give steroids for 3 days, solumedrol, and early ambulation and vestibular rehab. Drugs for not more than 3 days. Many people put these patients on drugs for a long time and it interferes with recovery. So, vestibular neuritis is quite treatable. It's not very common. Then we come to recurrent positional vertigo. And of course, the biggest thing here is BPPV. We'll hear more about it. Just remember, these patients are, we don't have the sound, unfortunately. These patients are extremely scared and it's not a benign condition. When you say benign positional vertigo, it's not benign. You got to get it to understand how scary it can be and how much it can throw a person off track. So the history is very suggestive, but that's not enough to make the diagnosis. You need more. You have to provoke the attack, and there are various ways of provoking. One is the Dix-Hallpike maneuver. You take the patient's head down like this and look for the provoked nystagmus. There is a latent period, and then it will start. See there, she's getting this. She's getting a downbeat nystagmus. It's a different type of BPPV. In your clinic, because of space, it might be easier to do this side lying test. So you just make the patient turn the head 45 degrees to one side and make him lie down on one side. And with a short latent period, you see the typical nystagmus. So this is right posterior canal BPPV. And then there is the roll maneuver for lateral canal. You just ask the patient to roll on one side and you will see a different pattern of nystagmus. This is horizontal nystagmus, not torsional upbeating. So this is horizontal. Okay, the problem with the Dix-Hallpike is it's not done because bed is not suitable, but then do the side lying. You are sometimes kind to the patient. You don't want to trouble a patient who's already feeling dizzy and you are worried about injuring his back or neck. Sometimes it's not done adequately, not the proper angle. You don't wait long enough or you don't look at the eyes. So important is get the angle properly. The head must go down and do it properly. Observe the eyes for at least 30 seconds. Keep looking at the eyes when you take the patient down and make sure you are observing it. Do whatever you can, but make sure you see the eyes. Patients who feel vertigo, they try to close their eyes. You must look at the eyes. Some reasons BPPVs missed it because the patient didn't call it vertigo. I've had patients who called it headache. Somebody says, my head goes numb when I lie down and turn on one side. The minute somebody says, when I turn on one side, something happens, I look for BPPV. Or they didn't call it positional. They said I get vertigo for half an hour instead of it's supposed to be a few seconds. Or you don't do the test properly. Video Frenzel makes life easy. You can see the eyes very clearly with that. There are various types of video Frenzel. Now this patient has got again upbeating torsional nystagmus. But don't relax just because you found it on one side. Always check the other side also. Sometimes you can be surprised. It can be bilateral. So this lady had on the right, but we repeated, looked at it again on the other side, and she's got it on the left also. So check carefully, is it on both sides or one side only? This is a patient with recurrent attacks of positional vertigo, and 2 months somebody had tried repositioning, etc. But this is what he had. When he looks to the right, nystagmus to the right. When he looks to the left, nystagmus to left. This cannot be BPPV. You don't get gaze evoked nystagmus. So we did his MRI, and what he had is multiple tuberculomas, one in the posterior fossa, which was causing this nystagmus. Another 35-year-old guy came to me. He was lying in bed and his son fell on him while playing, and immediately he got positional vertigo. And thereafter, he kept getting every now and then, and people thought it was post-traumatic vertigo. They tried repositioning. His VNG showed apogeotropic pattern, means when he's lying on the right side, the nystagmus beats to the left. When he lies on the left, nystagmus beats to the right. So there are some types of BPPV which are like this, but since multiple attempts had failed, I said no, we got to look at something else. And he had a large tumor in the center of the fourth ventricle. So when the boy fell on him, that triggered it all, but it was all due to this tumor. So be careful. There are patients who have what looks like BPPV. The patient has subjective BP. He says, I lie down, everything spins. I turn on one side, it spins. You don't see any nystagmus. Be careful. It can be BPPV. If you do a repositioning and it goes, well and good. But if it doesn't go, look inside. There could be a tumor again. So central positional vertigo is a googly. Very often it is due to migraine, but you have to look for cerebellar tumors, etc. Recurrent spontaneous attacks, the most dangerous one is a TIA. The commonest one is vestibular migraine, and Meniere's is overestimated, but it's the one which first comes to mind. So this is, you don't want this to happen. This is a patient with locked-in syndrome because of a missed TIA. Uh, since we are running short of time, I won't go. Sometimes you are lucky to see an attack. This is a 60-year-old guy who came with recurrent attacks of vertigo, and in the clinic, he got an attack, so we could see the nystagmus. And he had a small infarct in the brainstem and cerebellum. He had a very bad basilar. It is rare to have an attack in the clinic. Typically, it's only history. There are no findings when you examine the patient. So try to get a home video. Explain the patient how to take a home video of the eyes, how to switch on the video, the light, etc., and get a proper video of the eyes. And always keep TIA at the back of your mind, even if there are no other symptoms. Be reluctant to diagnose Meniere's because it's not really treatable. So always look for BPPV in addition, particularly if the person with so-called Meniere's has positional vertigo, and think of vertiginous migraine. It is a very close mimic and is much more treatable. So only if the person has progressive hearing loss, think of Meniere's. Otherwise, it is migraine. And vestibular migraine is the chameleon. It can mimic anything. So headache can be deceptive. The patient may not call it headache. Some of them just call it acidity, or they may not think it is related. And the patterns of vertigo, patterns of nystagmus are all multiple. So how do I treat it? I just give SOS drug, and if frequent, like with migraine headaches, only more than 2 or 3 attacks a month, then prophylactic therapy. And what about Meniere's? Again, I use SOS drug, low salt lifestyle measures, Dimox, etc. I do not give the 48 mg and other tablets for lifelong or months. That is, there is no evidence for that. So constant imbalance, no attacks. These are the patients right from brain top to bottom. You can think of Binswanger's, extrapyramidal disorders like Parkinson's, cerebellar ataxia, peripheral neuropathy. Diabetic neuropathy presents with imbalance. They don't call it imbalance. They say chakkar aata hai. So these patients who have imbalance are not really vertigo. Be careful. And Parkinson's can be subtle. There can be a very mild tremor. Just because she's young, it can be missed. Again, another young boy, you can see the left hand, he's got tremor and reduced arm swing. So when Parkinson has less tremor, is young, it can be missed. You can have internuclear ophthalmoplegia like this lady. I just got a minute more. 1 month imbalance, this boy, he looks to the right, nystagmus to right, looks to left, nystagmus to left. Obviously, this can't be a ear problem, and he's got a pontine glioma. Sometimes the gaze-evoked nystagmus can have a twist. It looks asymmetric. When he looks to left, it is coarser nystagmus. When he looks to right, it is a finer and faster nystagmus. This is what is called Brun's nystagmus, and typically it happens with a CP angle tumor. So this person has a CP angle tumor there. If you have downbeat nystagmus, we all know you look at the back of the head, craniovertebral junction. It could be an Arnold Chiari. This is a lady who was unable to sit or stand, and she has opsoclonus. So again, various eye signs. This is another one with convergence retraction nystagmus. Look at the nose. You can see both eyes coming towards the nose. So this is convergence retraction nystagmus, and she's got a pinealoma. Another boy, 3 weeks unsteady, and he's walking. You can see that when he walks, he loses balance. So he's got subacute combined degeneration. I won't go into that. So to the last 2 slides, chronic vestibular insufficiency presents with bilateral head impulse positive. They may be streptomycin or some other drug, but often they are idiopathic and just people lose vestibular function. PPPD, I won't go into it, but this is a very common disorder. Any trigger, it could be BPPV, it could be vestibular neuritis. This triggers this triple PD in anxious people, and then they keep feeling dizzy. They can be treated with SSRIs, physiotherapy, and rehab and reassurance. So the take-home message is, listen carefully to every dizzy patient. Is it an attack? If it is an attack, is it the first attack or are there recurrent attacks? If it's first attack, be very careful. If recurrent, is it positional or non-positional? And remember, imbalance is mostly neurological, sometimes bilateral vestibular failure. Don't miss a stroke in the first attack. Don't miss central positional vertigo tumors looking like BPPV. Don't miss Parkinson's and other neurological disorders who come with unsteady gait but are calling it dizziness. Remember, all these conditions are very treatable. Is one chance for doing magic in neurology is BPPV. Migraine also is very treatable. Vestibular neuritis is very treatable. And PPPD also responds very well. We used to call them psychogenic dizziness, but that is not a good word to use. Tell a patient everything is psychogenic, it's nothing, don't worry. No, that doesn't help. You treat PPPD properly, they improve. And sparing use of anti-vertigo drugs, as I said, 3 days vestibular neuritis, migraine SOS only, and BPPV only if out of town or he's got a recent fracture or something like that and you can't do repositioning, then only drugs. So finally, no drugs for imbalance. Remember that imbalance does not improve with drugs. You have to treat the cause or do rehab. Thank you. Sorry for going over time.
Thank you, Dr. Sudhir sir. Excellent presentation. You really made DG patient how to diagnose. Any query from audience? Mike? Mike.
Kothari, you rightly said it is simple but not easy. There are other metabolic causes also actually we create problem like patient hypertension, diabetes, hyperglycemia, hypoglycemia, uncontrolled hypertension, even the hypoxic also. So the anemia also, and there are all patients which also at times become confused because it's not a simple diagnosis and it required quite an intensive approach for that matter. When you have a epidemic of so many this thing vascular disease, diabetes related, hypertensive, I think at times the neurological diagnosis takes backseat. So we are basically occupied with other diagnoses, simplified like anemia and hyperglycemia, hypoglycemia, and by the time this diagnosis is, there is already damage is done. So I think involvement of a neurologist in early part for these kind of confusing symptoms and at time when it is not clear is very, very important. So please, sir.
Sir, wonderful presentation. Sir, do you believe in an anterior canal BPV when you get positional vertigo only in the vertical direction? Some people you don't get onto the side, only vertical direction.
Yeah.
So do you think it is a...
So when you get up and lie down, there
Yes.
are patients who say they're sleeping in bed in the morning. When he tries to get up, he gets thrown backwards. He tries to get up, gets thrown backward. These are typically posterior canal. So looking up, looking down, these patients are posterior canal, the commonest canal. And those who get on turning on one side are typically lateral canal.
Do you think
But
there
you
is
can't be sure from...
Do you think there is an anterior canal BPPV?
Anterior canal is extremely rare, maybe 1%. I used to think many of the patients I get are anterior canal, but they are a different type of posterior canal. Many times it is called apogeotropic posterior canal. So it is posterior canal. So anterior canal is very unusual to get BPPV because it is in front and typically it drains. So usually the particles will not remain there. So it is not common. When you get downbeat nystagmus, be careful, look for something else.
And sometimes people miss BPPV. It goes for years and years. Do you have patients like that? Because never anybody has done a Dixalpac test. And still after some 7-8 years when they come, you check there is a positional component. And when you correct immediately, they are okay.
Absolutely.
So, you can go on for...
Absolutely. My record is 25 years. There was a lady who was sleeping with 4 pillows because she could not lie down. She would put 4 pillows and sleep like that. And she was from Japan, so they were so happy.
Okay, so one last comment. In the functional vertigos,
Call it triple PD now. We don't call it functional.
Triple PD, please ask our camphor and the toothpaste containing camphor because now you just stop it 2 weeks, they are better. So it may be a slow toxicity of camphor and eucalyptus and other things. Okay. So please keep that in mind. Thank you. Okay.
Patient doesn't improve, can we do the second time correction also, sir?
Good question. So you have to see whether it is getting corrected. Some people do just once and send the patient off and say that you come back after 3 days. I like to do it immediately again and see has it gone or not. If it hasn't gone, I repeat till it goes. or then I give up and say, okay, I'm not able to reposition, come again. So you have to repeat.
I had two patients who didn't improve with the first Gufani measure, but later on, I think the second time it was done and they perfectly became all right.
Yes. So if possible, you should try to repeat it same time so you know that you have succeeded.
Thank you, sir.
So, thank you, Dr. Kothari,
Thank
for
you.
wonderful
Thank you.
presentation. I think I will have a round of applause for him. So now we move on to another presentation, My Move, the maneuvers to treat different types of BPPV. So our speaker is Dr. Anirban Biswas. Actually, he'll be taking us through this topic. So we have allocated time of 25 minutes, sir.
Mostly, yes.
Idealization.
Well, this thing is on. So can I start now? Okay. So my topic is this: benign paroxysmal positional vertigo. Well, as Sudhir said, that people with benign paroxysmal positional vertigo are scared and they feel extremely, extremely petrified of it. Petrified. Yes, that's the word. If the patient is scared, as a doctor practicing for the last 35 years in neurotology, I am 100 times more scared when we get a patient of BPPV. BPPV is the most difficult part of neurotology, and we hold workshops for 2 days on BPPV only. In 20 minutes time, I am not sure how much we'll be able to cover, but a little bit, let's get a glimpse of it. But one thing, BPPV is not only Epley's maneuver, and it is not only the Dix-Hallpike test and Epley's maneuver. There is a much, much beyond that. So that is it. You'll be getting all these different types of eye movements in BPPV. Left beating, right beating, up beating, down beating, rotatory, everything is possible. It depends on which position, what type of nystagmus you are getting. So let us see how much we can get into it. The basics of BPPV. What causes BPPV? Otoconia trickle from the utricle, enter one or more, usually one of the semicircular canals. Head movement only in the plane of this semicircular canal induces movement of otoconia in this semicircular canal. Movement of otoconia in the semicircular canal per se does not cause vertigo. Only when the movement of otoconia takes place in the canal if the canal is in the plane of gravity. If the canal is in the line of gravity, that is in the vertical plane, then only the head movement in that direction will generate the vertigo, the nystagmus and the vertigo. By looking at the direction, the intensity, the latency and the duration of nystagmus, we can determine the which semicircular canal is harboring the otoconia, as well as the precise position of the otoconia in that semicircular canal. See, there are two things. We have to know which canal, and also in that particular canal, which part of the canal has the otoconia. Then only you can take it out. So the clinician's job is first to identify the semicircular canal in which the dislodged otoconia are present. Secondly, to determine the location in the location of the otoconia in the affected semicircular canal. And then once this has been done, reposition the otoconia back into the utricle. So that is what we are supposed to do. And this is the utricle, this is the utricle and the three semicircular canals. Now, if you can do this, then you can give immediate cure and instant relief to the patient, and nothing is more gratifying than curing a patient of BPPV. But it's not easy. Some basics of BPPV continued. BPPV is diagnosed by placing the head in different provocating positions that are specific for each canal. These specific positions are particular head positions when that semicircular canal is in the line of gravity. Now, the provocative positions for each semicircular canal are different. For the left Dix-Hallpike for the left posterior canal, right Dix-Hallpike for the right posterior canal, the left supine roll for the left horizontal canal, right supine roll for the right horizontal canal, and head hanging for both the anterior canals. So that is how we have to put the head in that provocative position that canal has to be put in this provocative position, then only you'll be able to generate the nystagmus. Within this semicircular canal, movement of otoconia in one direction will stimulate the semicircular canal, and movement of otoconia in the opposite direction will inhibit the semicircular canal. Inhibition will cause one type of eye movement, excitation will cause another type of eye movement. These are the problems. Stimulation of the semicircular canal induces stronger nystagmus in one direction, and inhibition of the semicircular canal induces weaker nystagmus, but in the opposite direction. So you see too many permutations and combinations, and depending on the semicircular canal affected, the intensity is comparatively more in one head position and it is absent or much lesser in the other head position. So you see how complex it is becoming. So hence, to test for BPPV, we need to do the Dick-Solpike test, the supine roll test, and the head hanging test, and then ascertain the nature of the generated nystagmus. So these three tests we have to do whenever the patient presents with a complaint of getting giddiness on change of posture, and patients will not always say that they are getting giddiness on change of posture. Whenever a patient of vertigo comes to you, always do these three tests: the Dick-Solpike test, the supine roll test, and the head hanging test. From this semicircular canal harboring the otoconia and the precise location of the otoconia in the semicircular canal can be precisely identified and known. Now you see, these semicircular canals can be in the disposition of the two semicircular canals. When you are sitting in front of the patient, these are the three semicircular canals on the right side: the right anterior canal, the right lateral canal, and the right posterior canal, and the left anterior canal, the left lateral canal, and the left posterior canal. Otoconia dislodged from the utricle may be lodged in any one of these 6 semicircular canals. Now, the relevant anatomy of this semicircular canal. The semicircular canal is like this. This is a diagrammatic picture. Semicircular canals have two ends. So this is the semicircular canal. It will have two ends. One end is the ampullary end. This is the ampulla, and this is the utricle. Semicircular canal will have two ends. There will be one dilated ampullary end on this side, and there will be one dilated ampullary end on this side, and this is the narrow non-ampullary end. And there is the ampulla over here. Inside the ampulla there is the cupula, and the cupula runs through and through the ampulla. That means particles from this side cannot go to this side, and particles from this side cannot go to this side. So if the particle is on this side of the ampulla, it has to enter the utricle from here, and if the particles are on this side of the ampulla, it has to enter the utricle from this side. So this is the first thing that has to be understood. Then secondly, now in each semicircular canal, there are 5 locations where the otoconia may be lodged. It may be lodged in the ampullary end over here. This is called canalolithiasis. It can be lodged in the non-ampullary part. This is called, again called canalolithiasis, but in non-ampullary canalolithiasis. Particles can be lodged in the short arm side also. So as we said that there is an ampulla over here, and there will be a long arm and a short arm. So it can be in the long arm, it can be in the short arm. And the particles can also lie on the cupula. It can be, this is called cupulolithiasis. Cupulolithiasis means particles can lie on the cupula. It can be on the long arm side of the cupula, or it can be on the short arm side of the cupula. So there are 6 canals, and in each canal there are 5 positions where the particles can be there. So clinician needs to find out the precise location of the otoconia in the 30 possible places, and then send the otoconia back to the utricle by the designated liberatory maneuvers. For each of these 30 positions, there will be 30 different types of maneuvers. And for each of the 30 locations, so there will be 30 different maneuvers. So it's not that easy as it appears from outside. Now the relevant anatomy, there are the canals. These are all paired canals, and as you know, these are all these canals are all paired, and the left horizontal, right horizontal is one pair, left anterior and right posterior is one pair, right anterior and left posterior is one pair. So there are 3 pairs, And each of these semicircular canals is connected to two extraocular muscles, one one on the ipsilateral side and one on the contralateral side. And contraction of the two extraocular muscles will spontaneously induce relaxation of two antagonist extraocular muscles. That this will help facilitate the eye movement. Why are we saying this? Because this background has to be understood for you to identify which canal has been affected. And until you can identify which canal has been affected and what is the eye movement that can be generated, you will never be able to put the particle properly into the utricle bag. And what we get in practice is that everybody, even physiotherapists now, are doing these maneuvers. And whenever they do the maneuver, they are doing it wrongly. And what happens is, particles in one canal, they become multi-canal, and it becomes very, very difficult to then set these things right. So you have to understand the theory behind what we are doing. Now, you are all all are neurologists, and I need not tell you that each of the semicircular canals are connected to two extraocular muscles, one on the ipsilateral side and one on the contralateral side. And for each canal, there are specific two extraocular muscles. Hence, what will happen? Stimulation of the right posterior canal. If you know that this muscle is connected to that canal, and if you know that these muscles can bring about this type of eye movement, then it will become very easy for you to identify which canal has been affected. And then by looking at the eye movement, you'll be able to find out where the particles are. So I'll just give an example. Like in the right posterior canal, if you stimulate the right posterior canal, which happens as in posterior canal BPPV, there will be contraction of the right superior oblique and the left inferior rectus, and relaxation of the right inferior oblique and the left superior rectus. This will generate a slow eye movement vertically downwards with torsion to the left side. So what will be the nystagmus? Nystagmus will be opposite to that. So nystagmus, the first phase, will be upbeating with torsion to the right side. So whenever you are seeing a nystagmus, you will have to understand that the actual eye movement was exactly opposite to that. When you know that what was the opposite eye movement, then you will know that these muscles could have caused this eye movement. And from that, you will have to understand that this is the canal that is affected, because you now know that each canal is attached to two extraocular muscles. So that is how you can find out which canal has been affected. And this is extremely important to know. So each semicircular canal is attached to two specific extraocular muscles that can only generate one specific type of eye movement. The semicircular canal with the otoconia can be stimulated only when the head is in a specific position where the plane of the semicircular canal is in line with gravity. No stimulation of the semicircular canal will occur in the other planes. So you see, you have to see the eye movement and find out that in which particular position that eye movement has been generated. Hence, by noting the eye movement and the head position that has generated the eye movement, the specific canal stimulated by the otoconia can be ascertained. So it is possible. I'll just give you one example of that, then we'll go into the maneuvers. See, this is what you are seeing is the right horizontal canal has got the otoconia. So when the right horizontal canal is stimulated, what will happen? There will be contraction of the right medial rectus and the left lateral rectus, and relaxation of the contralateral muscles. So this will cause the eyes to move slowly leftwards, which is the opposite side of the stimulated canal. That means if the right horizontal canal is affected, eyes will make a slow movement to the opposite side, to the left side. That means the nystagmus will be a right beating nystagmus. So you see the nystagmus, imagine what could be the slow phase of it, that means the opposite eye movement, and then you know which muscles have been involved. And when you know which muscles have been involved, you can easily know which canal has been involved. So this scientific approach is necessary for you to identify the canal. It is not that easy that you just make the patient lie in one particular position and you know and you do a maneuver. So it is much more beyond that. So if you find that there is an upbeating nystagmus with torsion to the left side, what would it mean? It means that the eye movement generated by this in the semicircular canal is vertically downward with torsion to the left side. we know that the posterior canal stimulates the ipsilateral superior oblique and the contralateral inferior oblique. And so that means the right posterior canal had been stimulated. And if it is the right, and if this right posterior canal has been stimulated in the right Dix-Solpike position, it would mean that there are otoconia in the right posterior canal. So you see, this is what is important for you to understand, that each eye movement has to be very, very thoroughly analyzed. I have only about 5 minutes left. Okay. So the clinician's job is this: canalolisthesis can be there and cupulolisthesis can be there. And in each canal, there are 5 positions where the particles can lie. By noting the direction, latency, duration, and intensity of the nystagmus, the clinician can ascertain the precise location of the otoconia in the semicircular canal. And only when the precise location of the otoconia within the semicircular canal is known, can the corrective maneuvers to reposition the otoconia back into the utricle be done. Now we go directly into the canals now. With this background, we have to analyze the eye movements. Now, posterior canal BPPV. See, we do the Dix-Solpike test. This is the Dix-Solpike test. Step 1 is patient lies on the table with the legs extended, then head is turned 45 degrees to one side. Patient made to lie down with the head turned 45 degrees to one side, 30 degrees below the horizontal, and then the patient is made to sit up. So you look at for any nystagmus once in the head down position, and again when the patient has been made to sit up. You need to look at both, because when you are making the patient lie down, you will be getting a type of nystagmus. That means here there will be a left beating a left rotatory nystagmus beating towards the ground. But when you make the patient sit up, the nystagmus will be exactly opposite to that. So they both have to be seen. Then only you will be able to identify that it is over there. Now let us see what happens actually. Now you just imagine this. When the patient was in the sitting position, when the patient was in the sitting, see, I'm not getting space to wait. So I'll just show you over here. When the patient is, see, when the patient is lying down like this is a Dix-Solpike position. We are finding that let me start from here. See, when we are making the patient slowly lie down, the particle, the otoconia shown by the black spot over there is moving away from the ampulla. That means ampulopetal movement. When this is happening, the canal is getting stimulated, and so you are getting a nystagmus, a strong nystagmus. But when you are making the patient sit up, what will happen? The opposite nystagmus will take place, because now the otoconia is going near the ampulla. This is called ampulopetal movement. In the posterior canal, ampulofugal movement, particle moving away from the ampulla will cause stimulation, and it going towards the utricle, towards the ampulla. There's no space over here too. And the thing moving towards the utricle, I'm not, see, this is going away. I'm not getting space over here to move that is why I'm not being able to show here. But anyway, this is something which has to be understood over here, that there's no space to show it. But then I believe this has been communicated well, that if the particles move towards the ampulla, patient is sitting up, there is one type of eye movement. And if the patient is going away, there will be, when the patient is making to lie down, there will be stimulation. When the patient is made to sit up, movement will be in the opposite direction, and this will generate the opposite type of eye movement. So this is what is extremely important and needs to be understood. Then only you'll be able to do it. Now, what would have happened if the particle, now let us just see it over here. I believe this is the last thing that I'm able to show here. Now, when the patient, now supposing the particle was, well, let me stop it over. Supposing the particle is, wait, let me stop it over here and see. See, supposing the particle is at this particular position. At this position, this is where is the particle now. Initially, we had seen that the particle is in the long arm, over here near the ampulla. Supposing the particle is at another place, that means the particle is on the other side, the narrow non-ampullary end. If the particle is over there, then what would be the nystagmus? This is what you have to see. If the particle is over here, then what would be the nystagmus? If the particle is over here, then when the patient is lying down, the otoconia is moving towards the ampulla. See again, when the patient is made to lie down, the otoconia is moving towards the ampulla. When it is moving towards the ampulla, it would mean that it is inhibition. Inhibition will generate one particular type of eye movement, but that means inhibition means less eye movement and it is in one particular direction. Now, when this patient, when we is made to sit up, when we make the patient is made to sit up over here, see, then the otoconia is moving away from the ampulla. When the particle is moving away from the ampulla, it is causing stimulation over here. So the eye movement will be opposite. So in this particular patient, if the otoconia is in the non-ampullary end, when you are making the patient lie down, you will be getting less nystagmus and nystagmus will be beating towards the other eye, agiotropic nystagmus, but mild. When you make the patient sit up, there will be stimulation and the patient will be getting a stronger nystagmus. So if in a patient you will find that when you are making the patient lie down and that is causing more nystagmus, it would mean that the particles are in the ampullary end of the posterior canal. But if the opposite happens, that when you made the patient lie down, there was one type of nystagmus, and when you made this patient sit up, there is a much stronger nystagmus. It would mean that the particles are in the non-ampullary end. See, these things are all extremely important. I believe my time is now up, and so hence, if otoconia are in the non-ampullary end, patient will have a very mild vertigo nystagmus in the Dix-Solvay position, and nystagmus will be downbeating with torsion to the left side. That is towards the ceiling, apogiotropic nystagmus. But on sitting up, there will be excitation in the posterior canal due to ampulofugal movement, and hence intense vertigo nystagmus will be upbeating with torsion to the pathological side. So you see, this is extremely important, and these are the diagnostic criteria for and what we do. This is the Epley's maneuver. You just see it once over here. We turn the head towards this side, make the patient lie down like this, look at the nystagmus. There will be a nystagmus beating towards the floor, rotation, and towards the affected ear, if it is on the left side. Then we look at the nystagmus for some time. Then when the nystagmus stops, we turn the head for 90 degrees to the other side. Then the patient's entire body is rotated 90 degrees to the other side, wait for 30 seconds, and then the patient is made to slowly sit up. So that is the entire process of the Epley's maneuver. There are numerous maneuvers, and it is not possible to show all the maneuvers during this time. I have already run out of time, and we have had a very kind chairpersons who have not stopped me as yet, but then I believe I should not be taking advantage of that, and this is what we should ultimately show. Now you see over here also, when you have seen this, if you do it by animation, I think it will be easier for you to understand and see in the animation part. See, this is how the thing was in the animation. I just show you like this. It is much easier to understand. You see in the animation part, patient is this for the left side. Please maneuver then turn the patient to this side. Then you do this, and then you make the patient sit up. So you see, these are things. If the particle was in the short arm over here, then what would have happened? If the particle was over here in the short arm over here, see, I'm not getting space. If the particle was over here, this is the short arm, and the particle is over here. Then when you make the patient lie down, there will be practically not much of any nystagmus, because when you make the patient lie down, this will come down over here, and the particle will be moving towards the ampulla. That means ampulla petal movement, which in posterior canal is inhibitory. There will not be much nystagmus. There will be no nystagmus when you do the Dix-Solvay test. But when you make the patient sit up, then the particle will move away from the ampulla over here, and then there will be upbeating nystagmus and torsion to the left side. And the treatment for this is completely different. It is treated by a brisk Epley's maneuver, or the side-leg maneuver with the vibration placed on the lesion side, or a brisk Epley's maneuver. So this is what is done over here. This is a brisk Epley's maneuver if the particle is in the short arm. So what I intend to convey over here is that there are numerous positions where the particles can be, and you have to understand by looking at the eye movement where the particle is, do the Dick-Solpike test, supine roll test, and the head hanging test properly, so that you can identify and then do the corrective maneuver, because without that nothing is possible. And this is the horizontal canal. We do it by the supine roll test over here. This Sudhir has already shown.
Dr.
We are not
Vishwas,
going
I
into the
think,
details for that.
Dr. Vishwas, you have to
Yes,
conclude your
I
session.
believe we are finished over here. I'll just show you one example of this and then we'll stop over here. See, this is how it is. This is what is a geotropic nystagmus and what is an agiotropic. This is what is a geotropic nystagmus. You'll be seeing over here beating towards the ground. That means the particles are in the canal. If the particles are in the cupula, you'll be getting an agiotropic nystagmus beating towards the ceiling. So by that you know, and for each maneuver there are different types of things. And this is the anterior canal. Again, there are different types of tests, different types of things. And the echovenous maneuver is done for that. The take-home message is BPPV is the commonest cause of vertigo, can be easily diagnosed and treated. And if treatment is done correctly, it is very gratifying and offers instant relief. BPPV can only be treated by maneuvers. Medications have no role whatsoever. Faulty maneuvers by paramedics can only complicate the BPPV more. Clinical tests and corrective maneuvers need to be done only by medical personnel with deep insight on the pathomechanism of vertigo of BPPV. And BPPV can only be learned through dedicated hands-on workshop. If I get an opportunity of conducting a one-day workshop, I'll be very happy to do it. Thank you. Extremely sorry for taking more time. But you see, what I needed to convey is that it's a very complex thing and it should not be taken lightly. And the maneuvers have to be done well. And since this is 32% of all patients presenting with vertigo, it is something which everybody should learn. Thank you very much. Thank you. And sorry again for taking.
Thank you, Dr. Vishwas.
Thank you.
Thank you,
Dr.
we have
Biswas.
overshoot the time. I think there is no time for discussion. I will conclude our session here only. Thank you very much, sir.
Thank
you. Well, I think the first session is over here.
Thank you. Over to organizers.
Thank you so much to all the chairpersons, and thank you, Dr. Sudhir, Dr. Anirban Biswas,